Okay, so part two for chapter 45, we stopped with this slide, so stroke findings. So possible things we're going to find with the patient. So different things we're going to go through here. So sensory, so evaluation of touch and painful stimuli. So depending on what part of the brain has been affected, it's going to, it's going to change the sensory for the patient. So evaluating if they can feel that painful stimuli, like, they'll use it's not like a pin, but it's a sharp object that they use to stick into like the feet to check perception on some patients. But anywhere, we're going to check to see if they can feel different things that to note where the stroke has happened. We're going to evaluate their pupils for constriction or dilation, as well as ptosis, that's eyelid drooping. So looking at the pupils for PERLA. Sometimes a patient's pupil will be quite dilated, and you'll hear clinicians say like they've blown their pupil. And then, if it's overly constricted, we know we've got some kind of something going on. Evaluation of nystagmus, which is involuntary eye movements. And then, so our cranial nerve function's another thing we're checking for. So most likely the facial nerve is going to be affected. We talked about that again with Bell's palsy prior to this. And so I'm going to be evaluating for that. I would see that in like the droopiness. And then the gag reflex and impaired tongue movement, those cranial nerves can also be involved. And the patient may have dysphagia, difficulty chewing or swallowing liquids or foods. Cardiovascular, so I need to make sure that I'm definitely doing evaluation of dysrhythmias. The doc will likely order a EKG that we're going to perform. So again, AFib causes clots to be thrown into the blood system, and for each class, we're going to go through cardiovascular, but I will definitely go into depth with AFib, and we'll relate it back to this. Just be aware at this point that a dysrhythmia like AFib, which is atrial fibrillation, can cause blood clots to be thrown into the blood system. Blood pressure, so it's going to be normal for us to find the patient come to the hospital with a really high blood pressure. This is the body's trying to compensate and get that blood flow to the brain, because if it's blocked and something's happening and there's tissue death happening in the brain, the body's trying to get enough pressure up there to get the blood flow to the different parts of the brain. So anywhere between 180 over 200 and 110 over 120 is going to be a blood pressure that I'm going to see in a patient that comes in with a stroke. A somewhat higher pressure is needed to maintain that cerebral perfusion, as I was just saying, after an ischemic stroke. So docs will a lot of times order us to try to keep the blood pressure around 150 over 100, so we can perfuse the patient's brain. However, pressures above those values can actually lead to another stroke, and obviously if we've got a hemorrhagic stroke, we're not going to be wanting to have that blood pressure like that. Another area that I need to be working with the patient is in their psychosocial. So your book says most stroke patients are typically older 60 years old. But again, we know that's not universal and not the case because we have younger and younger people now today. But so I know I'm dealing with a patient that's 60 or over for the most part. So I need to assess the patient's reaction and what's happening. Remember, we get so caught up, especially in areas like med-surg, of treating the physical stuff that we forget about the person. And it's so easy and happens so fast. And I know for sure as a nurse, I was guilty of doing this because there's so many problems happening that I just want to fix the person and I forget they're there watching me do all these things. So I want to identify the coping and personality changes with help from the family, assess emotional lability, especially if the frontal lobe of their brain has been involved, so the patient can go from crying to laughing back to crying. This is very normal for somebody that's had frontal lobe involvement. So I want to teach the family that personality changes and emotional lability can be normal findings in a person who has suffered a stroke. And so I need to know that too. The patient is not just acting weird or not having inappropriate responses, like thinking it's actually funny that they've had a stroke. They truly have had this brain change, and I need to be aware of that. So We're going to go into thrombolytic therapy, also known as clot-busting drugs. So this is IV thrombolytic therapy. It dissolves the cerebral artery occlusion to reestablish blood flow and prevent cerebral infarction. You'll hear this called TPA. Alteplase is the only drug approved at this point for treatment of acute ischemic stroke. And then I went and grabbed this off of the TPA's website. Did you know the FDA stated that TPA is the abbreviation for the drug class that encompasses all tissue plasminogen activators? To avoid confusion and medication errors, it has recommended that healthcare professionals use either the brand name Activase or the generic name Alteplase in written prescriptions and verbal orders. So I just thought that was interesting, grabbed it. Actually, the site is great. You can, if you just Google Alteplase or Activase, it pops right up as one of the first ones. And their site is super helpful. So if you want to learn more about this medication, it's going to be, if you're working in an ER, you're definitely going to end up getting familiar with it and using it. So it's good information. So the most important factor is whether or not we're going to give TPA. So we have to determine what type of stroke it is, because if it's an ischemic stroke and the patient is a candidate, then they're going to get it. If it's hemorrhagic, they are not. And I hope that makes sense as to why they wouldn't, because this is a clot buster and it's going to cause breakup of a clot. So if it can do that, if I have a hemorrhagic stroke, it's going to make it bleed way, way more, and I'm going to probably kill my patient. So that's why we have to determine which kind of stroke it is. Time in which the onset of symptoms occurred and time seen in the stroke center is going to determine whether or not this is given. So all the way up until reading this chapter, I knew it was 3 hours. But in 2009, the American Stroke Association recommended an expanded time interval from 3 hours to four and a half hours, which is great. That gives us another hour and a half from the moment that the stroke was witnessed to the time that they arrived in the stroke center and get them in there to get the imaging done and find out if they can have the TPA or not. So I think that's great. I'm glad that they've extended that. Page 938 lists the categories in which individuals could not receive TPA, even if they are within the time frame. And I'm actually going to just read it right to you. So it says that we're going to give TPA to the patients unless they fall into these categories: if they're older than 80 years of age, if anticoagulation with an INR is less than or equal to 1.7, if their baseline National Institutes of Health stroke scale score is greater than 25, or if they have a history of both stroke and diabetes, which I didn't know that, and I didn't look into it anymore, but I'm going to, because I want to find out what the rationale behind that is. So if they've had both a history of a stroke in the past and are a diabetic, they are not a candidate for that. So then there's just all this other drug therapy that your book talks about. So the thrombolytics, obviously, to bust up the clots, the anticoagulants like a heparin drip to prevent more clots forming, or keeping the blood thin. And when we are in pharmacology, when we learn about anticoagulants, you'll learn that they don't bust up clots, but they keep the blood around it thin and keep the clot from building. Lorazepam and other anti-epileptics in case of seizures, calcium channel blockers for blood pressure, stool softeners, analgesics, and anti-anxiety drugs. So hopefully all those drug classes make sense for care all around for the patient who has had a stroke. And then promoting effective communication on 943 to 944. I want you to read through and know the following words. I'm going to go through the expressive and the receptive aphasia because they're going to be important for you to know these words, but all of them. So under expressive aphasia, also known as Broca's aphasia, this is from your book. Expressive or Broca's aphasia is the result of damage in the Broca's area of the frontal lobe. It is a motor speech problem in which the patient generally understands what is said but cannot communicate verbally. He or she also has difficulty writing, but might be able to write. Rote speech and automatic speech, such as responses to a greeting, are often intact. So, hello, hi, how are you? Good. The patient is aware of the deficits and may become frustrated and angry. We need to reassure the patient and remind them to talk slowly. Okay, so that's Broca's. That's in the frontal lobe, where the patient understands but cannot communicate verbally. Receptive or Wernicke's aphasia is due to injury involving Wernicke's area and the temporal parietal area. The patient cannot understand the spoken and often the written word. Although he or she may be able to talk, the language is often meaningless. Neologisms, which are made-up words, are common parts of speech. So the patient, in this instance, the patient cannot understand what is being said to them, and many times not what's written either. So between Broca's and Wernicke's, clearly it would be easier on the patient, though both are going to be very frustrating, to have Broca's, because they can understand, but they can't really communicate back, versus the receptive, the person can't understand what's being said to them. And then neologisms, the made-up words, are common parts of speech. They're not purposely doing that. When we get to mental health and talk about schizophrenia, neologisms are also a part of schizophrenia that we'll see. It is a positive symptom, because it adds to, the patient didn't have that before, and we actually do some fun activities with that. So anyway, moving on from that, make sure you read those pages, make sure you understand this stuff. We want to help the patient communicate using the following guidelines. These are from your book as well. Present one idea or thought in a sentence. Use simple one-step commands. So we want to give just one step at a time commands, not you need to do this, this, and this. Speak slowly but not loudly. Use cues and gestures. And that's really hard, guys, because we're used to, if we got to slow our speech down, we for some reason naturally correlate that with hearing loss, and so we speak loud too. Avoid yes or no questions, especially because this patient is having trouble either with understanding or with speaking. They don't like that that's happening to them, so they may just say yes because they'll see that it's going to help you. And so we really don't get good communication from the patient. We need to ask those open-ended questions and use alternative forms of communication if needed. So some patients might need, like, maybe they can use a writing board instead of having, doing the talk back and forth. And your book talks more about that. I'm trying to scan through to find where I saw that, but if you just make sure that you read those last couple of pages for the stroke. This is so important that you understand this, okay? So please, please, please do your reading, especially when following through with this. Take your notes for it. You're going to see quite a bit of this on the test. Okay, so that's it. We got through all of it, and then on to tomorrow. So I will see you guys.